Hello.
Hi.
Hello, everyone?
Can you hear us?
Yes.
Oh, great. This is Nick Naka.
Jade Malco, the Addiction Fellow. Tim is going to be hopefully joining remotely from Mexico soon.
Okay.
I think we'll get started.
Yeah, it's 1:15, so we can get started. I've got 2 cases to present, and then I will turn it over to Jade and or Tim if he finds a way to sign on from sunny Mexico. Let's see, do I have hosting, or do you want me to just ask you to advance the slides?
Whatever you prefer. Let me just make you guys panelists.
Yeah, if you wouldn't mind giving me the host, and then we can just advance slides and.
Sure.
I still have to
See if this works. And I'm now the presenter. Okay. So the first case is a patient we've seen recently on the toxicology service. This is a 35-year-old female. She presented to the, I have to thank my resident for putting the slides together. Thank you, Dr. Finnegan. She's a 35-year-old female who presented to the emergency department with abdominal pain. She had had mild abdominal pain on and off since her IUD insertion several months ago, but it got much worse. So she came to the emergency room. They did a CT scan. It showed some free fluid in the abdomen. They tapped it and sent it down for analysis, which was kind of drawn out and inconclusive. And the whole time she's in the hospital with abdominal pain. OB-GYN was consulted. They don't think it's ovarian cancer. The surgical team, I guess there was a couple of surgical teams that weighed in, and ultimately they decided that she needs an exploratory laparotomy to rule out appendiceal cancer, which is pretty rare. During this, when somebody said the word cancer, she became very anxious, and they started her on clonazepam, 0.5 milligram every 6 hours. She has a long history of substance abuse, which is why we're talking about her today. It's a kind of a classic history for how it started. Reportedly, she had a cesarean in 2010 and was discharged with hydrocodone, and the GYN, or the OB rather, kept refilling it at follow-up visits, so she became addicted to it. Eventually, they stopped, and she switched to stealing fentanyl from work because she was a nurse. And she got away with that for a while until she was ultimately caught, and she had to surrender her license and go into treatment. Switch, okay. So she went into an abstinence-based outpatient chemical dependency program and relapsed. She re-engaged in an interesting program that was specifically, it was a work-specific program where she was put into a 28-day program with other healthcare professionals. When she was discharged from that, she was doing well and was started on Vivitrol, which worked for about 1.5 years, but then she started to develop hives at the injection site. So they had to stop that, and they started her on Suboxone. And she'd been doing well for 1.5 years on Suboxone, which she was taking right up to admission to the hospital for this abdominal process. So they consulted us because her pain really wasn't controlled. They were giving her acetaminophen regularly, but nothing else, and other than her maintenance dose of buprenorphine. And they had also started her on clonazepam. So I think now is a pretty good time to open it up to the group as far as how they might, somebody might address this consultation. So if you could just raise your hand if you have any ideas as to what you might do. Not getting a ton of responses here, which is sometimes the case. I'm going to look through to see if there's anybody that I know that I could pick on. Not recognizing a ton of names. see. How about, I'm just going to pick out a name. Diana Dean? You're unmuted.
We unfortunately were late jumping in, so we missed the beginning of the. Is that us? Are we on?
Yeah, you're on. I can hear you.
Yeah, sorry, we missed the beginning of the history at the slide.
Okay. I'll go to somebody else. How about Ingrid?
Oh, well, I'm afraid I'm in the same boat as the previous speaker. I had some technical difficulties with my phone, so I saw the slides, but I wasn't able to hear, so sorry.
Okay. So just by a quick recap, so it's a 35-year-old female. She has an interesting history of opioid dependence disorder, managed well on maintenance therapy with buprenorphine 8 milligrams sublingually twice a day. Got admitted for abdominal pain, requires a surgical procedure in the coming days, and is in a lot of abdominal pain, and we were consulted to help manage the both the current pain she's in and then the pain that's going to be associated with her XLAP. How about Ron Kirshner?
So again, I missed the part of it, but now, so you're explaining it. So she has been taking her Suboxone, and
yep,
and she's going for surgery. If she had any kind of pain control at all, has she been taking anything for pain?
Just the Tylenol that they've been giving her, in addition to the Suboxone, which they're giving her sublingually twice daily.
I guess you could try using something that's a you could try a non-opioid. You could try something like ketamine as an adjunct to control her pain acutely. That might be one option. If she's an inpatient.
She is an inpatient. Do you work somewhere where you can do ketamine outside of the ICU?
Well, in a step down situation, you might be able to do it, but no, definitely would not be able to do it on a floor. I mean, you could do it in the ED perhaps, but that's about it.
Yeah. Do you have any thoughts about the clonazepam? They started it when they mentioned the word that the potential diagnosis of malignancy, because she became very, very anxious associated with that. So they started her on a half milligram 4 times a day of clonazepam.
So that's a new medicine for her.
It is, yeah. They started it once they admitted her to the hospital and said, "Oh, you got this ascites, and we don't know what it's from. It might be cancerous."
So that seems like that might be kind of a potential complication, that they're starting on a long-acting benzo that might potentially complicate things if you're going to use something that also could be a CNS depressant. Putting her on a long-acting benzo might not be the best thing.
Yeah, I'm with you. Let's see. Anybody else in the room have any other comments about this case, how they might approach a consultation like this? So I'll just tell you guys what we did, and maybe somebody will tell me how silly I am. Oh, what happened? We lost it. Okay, so our ultimately we had them change the acetaminophen from PRN to standing. We had them add an NSAID because there was really no contraindication to it, so we had them add Toradol. And we had them break up the dosing of buprenorphine, which we kind of do routinely, from a BID dose to 4 times a day. And our plan, I guess, moving forward, which we've been doing more and more frequently, was to keep the patient on the buprenorphine through the XLAP. The surgeon suggested maybe even discharge the day of the procedure. The team that was caring for her thought maybe that was a little preemptive. But our plan was through the procedure to use full agonists on top of her broken up continuous dosing of buprenorphine. People at other facilities, is that pretty standard? I'm always interested to hear if other folks are doing the same thing, because it's pretty much a routine recommendation for us when we're consulted on these cases. Anyone? How about Oregon? I'm going to unmute you here. Okay. So let's see, I'm going to unmute Derek Lung. Brought up a question. All right, go ahead.
Hi, so I'm just wondering about Suboxone. So what's the advantage of using Suboxone QID compared to BID?
So our experience in practice has been that it seems that the analgesic effect of buprenorphine seems to be shorter than the effect of staving off withdrawal. And so we find that patients' pain seems to be better controlled with more frequent dosing, even though it's the same total daily dose. But again, I'm interested to hear if anybody else on the line is providing similar recommendations. So either everybody's just too shy, or we're the only ones saying this. Hey, Dr. Perrone, can you hear us?
I can. Can you hear me?
Yeah. Do you? I know you do a lot of addiction stuff. Do you also provide similar recommendations for acute painful conditions?
Actually, I do very little addiction stuff, but we do a lot of buprenorphine from the ED. But I do have a question. I've been looking at Reddit forums for buprenorphine, and there is so much information on there about tapering and sort of different dosing intervals that help people combat different symptoms, either, spreading it out throughout the day with withdrawal and spreading it throughout the day with pain. I don't understand exactly enough about the pharmacology, about why splitting the dose multiple times a day, how it affects one thing versus another. Maybe that's part of what your question is, and I'd love to hear what your theory is on the answer. I've been told that, doing it twice a day is the way we should administer it for pain. And then and I know that when we start people, sometimes we're doing it twice a day for, the first couple days of induction. But I don't really have a good sense of why it's pharmacologically different in that way.
This is Jade. So as far as the half-life that we understand that Suboxone has, we sometimes talk about it when it's most related to it being in the body, treating dependence and withdrawal, and that can be over 24 hours, and it actually can be dosed as a daily medication if that's kind of how the center, if patients are in an inpatient program or even in the outpatient setting, Suboxone can be dosed as a daily medication without having the effects linger off. And kind of what Dr. Naka was discussing as far as the half-life effects and kind of the onset of analgesia effects and when that tapers off, we tend to see the first 6 hours or so the maximal analgesia. So when we talk about kind of outpatient standard dosing for dependence and withdrawal, I think daily or BID dosing is very much appropriate and works for many, many patients. There are a few patients that come across in practice that have said, well, splitting out my dosing is really what I need for dependence, and I think some of that can be kind of supertentorial, and I think we encourage them to stick on their BID or QD dosing. But for pain, certainly TID or QID with a PRN can often be helpful for these patients for pain. So when we consult on them in the hospital and they've been on a BID standing dose, we will split it and sometimes even increase their total daily dose to help with pain as well, kind of maxing out around the 24 milligram total daily dose, but on average around 16.
Yeah, maybe I could just ask all questions. They're probably really basic questions, but like, why don't people want to be on a higher dose? I mean, I know the feeling effect and all that, but it seems like it's a little bit.
You're cutting out just a touch.
Yeah, you cut out right at the end. You were asking why some patients want to be on a higher dose?
Why don't want to be on a higher dose?
Oh.
You know,
yeah,
like,
I think
they wanted more of everything else they had.
So I think it depends on kind of what context that's getting brought up in. Was there a particular situation that came up for you?
More to understand, we're trying to push the max just to 32 milligrams in a few hours in the ER. And most of my experience has been that patients aren't immediately interested in really high dosing, which doesn't necessarily sort of make sense. And you know, your hearing thinks that you can get them to 32 milligrams very quickly. So what are the reasons that patients don't want to get to that dose? Like I said, a whole that do you feel more antagonistic?
Well, so this is Gloria, and the most common reason I hear from patients as to why they don't want to get to a high dose is that they hope to go off of it at some point in the future, and therefore they want to only get to a certain amount because they feel they'll have an easier time of getting off of it.
Yeah, I mean, that makes really on it for, long setting where people are sort of a little exploring it or just treating withdrawal. So anyway, those might be a little bit elementary, but it's just sort of confusing me out as the people are trying to suggest that we should be using higher doses because it'll last longer, how the patient's response is to that, because we have not tried the higher doses, higher, like 24 to 32 milligrams.
Yeah. We've got another question from Jeffrey Bernstein. I'm going to unmute you.
Hi. I got booted off the call and had to dial back in, so I hope nobody has already suggested this. But was there any conversation about doing epidural anesthesia and leaving the catheter in, for the next 4 days or so?
We did not make that suggestion, though it's not a bad one at all. I think that increasingly with procedures that are not deemed to typically require a ton of pain management, as in this case where the surgeons were saying that normally they would discharge the patient the same day of the procedure. I think because of that, I kind of thought, okay, well, this is only slightly different with a patient who's on maintenance therapy, and so my gut and go-to gestalt is to use full agonists on top of their baseline medication and then to break up their dosing, and we tend to get away with that. If it was something like something that would deem to be more painful, more invasive, I think that we definitely would have considered that.
I don't think we've presented this case, and maybe it'll get presented in the future, but certainly we see a number of patients post like cardiovascular procedures after thoracostomies. LVAD insertion was a case that came to mind, but the surgeons and anesthesiologists worked pretty closely to make sure that we could do intercostal nerve blocks, and we had talked about doing continuous continuous bupivacaine infusions afterwards, although the patient didn't require it. But there are definitely options that I think is really important to get your anesthesiologist involved in because they can be really helpful.
We have another question. Elizabeth?
Yeah, I have a couple of questions. One of them is, I think, what Dr. Perone was asking, and maybe just a corollary. Maybe there's a better answer. But in terms of how methadone being used, Q6 hours for pain as opposed to once daily for addiction, and I'm wondering about kind of the pharmacokinetics. Is there something similar about that? But so that being one thing. And then with regard to this patient, how soon before and after the surgery are the folks comfortable with administration of NSAIDs? And then just an experience, and then the other thing is, if, in terms of an opioid agonist, when the patient is not taking PO yet, maybe early post-op, that fentanyl has about the same affinity or close to the same affinity to the opioid receptor as does buprenorphine, so that might be a consideration in terms of which short-acting opioid for a short time when it's IV. And then the last part, just an experience that we had with a patient who went to C-section sort of unexpectedly, but had a conversation with the anesthesia, and the plan was to do, initially spinal. They came back with the catheter in place, and two things happened. One is that the amount of time that patient ended up on bed rest was probably not the most optimal. And the second thing is anesthesia actually administered the anesthetic, but not the analgesic agent. So there was no opioid in the epidural, and they thought they were doing the right thing in terms of trying to minimize the patient's exposure to opioids. So just one sort of caution for something that happened with us. So bottom line, my questions are, again, is there any corollary to how methadone works with regard to the frequency of dosing, and then the NSAIDs?
Yeah, so this is Gloria again, and I'm the medical director of a methadone program. So I'd say methadone is pretty much the same thing. We often recommend when people are needing assistance for pain for them to divide their dose, but actually we as a methadone program don't recommend that because there's a lot of rules about this in New York State. We have to get them qualified for split dosing based on peak and trough levels. But when the person goes into the hospital, the people who are taking care of the person in the hospital can readily change the dosing to some kind of split dosing, either BID or TID or QID, whatever will work best. And I'd say most people who take supplemental methadone take it on a BID or TID basis.
As far as the NSAIDs go, there was, in this case, no contraindication to using the NSAID. According to the surgeons, it was cleared and discussed with the surgeons, and they didn't have a problem with using NSAIDs in the pre- and post-operative phase. Henry Swoboda. Hello?
Yeah, hi. I just wanted to comment on the split dosing, that with that, my understanding for methadone split dosing is that there's basically an alpha distribution phase and then a beta elimination phase. And so, you take it, your methadone goes to maximum concentration in whatever 2 to 4 hours, and then it rapidly redistributes in that alpha phase. So your serum concentration actually goes down fairly rapidly after that, within 6 hours or so, and hence the Q6 hour dosing for that. And then it hits its long elimination phase, that beta phase. And so that's the reason that you get these high peak levels, over 4 to 6 hours, but not so much, and then you hit steady state after that. My understanding with buprenorphine is that's not the case, and it's still not clear to me why we do the split dosing, but I definitely do it as well, and it seems to work, but the why of it I'm still struggling with in my brain.
So this is Gloria again, and the thing that always puzzles me is when I first began to read about buprenorphine, even before the Data 2000 Act, there were even some studies that suggested it be given on a 3-time-a-week basis, not even on a daily basis, because it had such a long half-life. So I find that very interesting, because I'd have to say that most of my patients are not in any kind of pain that I know about, but they prefer to take it for addiction reasons on a twice-a-day basis rather than a once-a-day basis. And I'd say at least 50% of them prefer to take it that way. So some centers are very strict about this and will only give it on a so-called once-a-day basis, but of course the patient can do what they like if it's an outpatient treatment program.
I mean, you know, as a psychologist, I wonder.
I do. I find that some patients tell me towards the early hours of the next morning, if they're taking it once daily, that they really do start to feel some symptoms, whereas if they break it up twice daily, they often tell me that that covers them a little bit better.
Yeah, I wonder if there's a psychological advantage to taking it more often. It better approximates their addiction behavior, and much of pain is emotionally mediated, or cognitively mediated. So it just may be part of the mechanism might be just being reassuring to the patient that they're going to get the next pain medication sooner rather than later. Just a thought, but.
All right, so for sake of time, I'm going to wrap up this case and move on to the next one. So, you know, as far as the clonazepam, we didn't really want the patient to be discharged on a benzodiazepine ultimately. So she's currently going to her procedure today, and they've maintained the baseline buprenorphine treatment. We've had them just, not that I think she's developed a dependence to benzos over the course of a few days, but we had them just taper just half the clonazepam every day so that as we get towards discharge, she won't go home with it at all. So we don't have a full conclusion, a post-operative conclusion, but this is one of many similar cases that we currently have on our service, and patients do very well when we break up the dosing, continue it through the procedure, and give them full agonists on top of their buprenorphine during the perioperative phase. So the next case is equally as interesting and exciting. It's a 57-year-old female, and she's got a history of dermatomyositis, Sjogren's, and other inflammatory arthropathies. She has chronic abdominal pain for which she was admitted to the hospital for failure to thrive. So her admission medications were numerous, but they included 90 milligrams of oxycodone immediate release every 6 hours. Those were 30 milligram tablets, and she was taking 3 of them every 6 hours. A milligram of alprazolam 3 times a day, and she was taking 1,200 milligrams of gabapentin 3 times a day. This was her, just a portion of her iStop record, which is, I think, was very impressive to me. And this was an interesting case because we were really consulted by the patient's primary care physician and outpatient pain management physician because they wanted to switch the patient to buprenorphine, which sometimes I feel like this is a new phenomenon, I think, that we're being asked to help providers with chronic pain conditions and using buprenorphine. The reasoning for which was that, number one, she continued to have pain. She described 8 out of 10 kind of joint pain, muscle pain, even after her dosing of 90 milligrams of clonazepam. And she was also getting very sleepy and somnolent throughout the day, nodding out. And her family was calling her a junkie and making her feel bad about that. And people were stealing her medications quite frequently in a way that sounded less like diversion and more like probably was actually happening. And like I said, even when she got admitted, the nursing staff was noting that she was getting the nods. So I guess, before I go on, I'll open it up again, and we'll see if we can get some people to weigh in on what they think about how they might field this consult in regards to how would you switch somebody from that dose of oxycodone over to buprenorphine? Or would you even? I'll too often get crickets. Henry, I still got your hand up, so I think you probably left it up from before. Oh, you put it back down. You're still unmuted, so you're on the...
Yeah.
What do you got?
I'm happy to comment it. I'll remember to put my hand down next time. Yeah, she's on pretty big doses of the oxycodone there. I think what we found is that that some degree of anxiolysis can make the transition a little bit easier, and so whether it's a benzo, which she's already on a bunch of, so that might not be the best choice for her. Perhaps an antipsychotic, and again, we try not to mix the benzos with olanzapine so much, so could consider giving her a little Haldol to help with as an antiemetic, and can help with some pain modulation as well as a little bit of anxiolysis with that. I might give her kind of before bed and hold her oxycodone, and I mean otherwise I would really kind of follow our typical pathway, just with that if they have objective signs of withdrawal and they're at least 12 hours out from their last opioid, that you can start giving them Suboxone. I would go very slowly with it, though, again, just to give her some time to metabolize. And so, I might give her 2 to start with, and then 2 a couple hours later, and then maybe try a 4, depending. So I would go slower with extra anxiolysis on board for, and if, it's still not clear whether you can give it, but it's been a good amount of time, and someone is taking it for pain, I mean, first you want to do the extra things for their pain, the Tylenol, the ibuprofen, all that stuff that's scheduled. But then if they're getting to where they might be ready for Suboxone, but you're not quite sure yet and they're complaining of tons of pain, we have given them some IV Buprenex for pain at that point, and have not run into precipitated withdrawal, as long as they're, starting to get to the point where they would be, potentially ready for an induction.
Dr. Vikas? Ingrid, are you on?
Yeah. I guess I'm not sure about the analgesic potency of buprenorphine in terms of whether this will be effective for her for pain control. The fact that her medications are being stolen from her is really quite concerning. So if in fact the idea is that, yes, buprenorphine would be a better choice for her for pain control, we have had some fairly good success, and this has been kind of only really recent for our opiate-dependent patients, so not pain control, because we don't deal with pain necessarily as such, by doing what's called a micro-induction. So where they don't have to be in withdrawal before you start them, because many patients don't tolerate any kind of withdrawal. They're afraid of Suboxone or buprenorphine for that reason. So she can continue taking her opiate, but start with half a milligram of buprenorphine, and then the next day you go half a milligram twice a day, then the next day 1 milligram twice a day, 2 milligrams twice a day, 3 milligrams twice a day, 4 milligrams twice a day, 5 milligrams twice a day, and then 6 milligrams twice a day. At that point, they're at 12 milligrams, and then see them back. We've even sent them home with a blister pack for that week. And then they have enough Suboxone or enough buprenorphine on board that then you can further adjust their dose after that. Many of our patients, if they're opiate dependent, are often on fairly large doses of street fentanyl or carfentanil, so we've been using bigger doses of buprenorphine. I don't know if this would be a way to transition her without having to decrease her opiate dose to the point that she's in withdrawal and further uncomfortable and may end up trying to get her opiate from another source.
That's a phenomenal comment. We didn't consider that, though I will in the future for sure. I can tell you the way I went about it, maybe a bit naively, but I was thinking about this, I guess, maybe with more of a toxicology hat on, and I was thinking about that dose of oxycodone and whether or not the kinetics are really the same as you would anticipate the kinetics of oxycodone to be when using it at the lower doses. And so my main concern was during the transition, how long of a washout period would that be? And I thought about just going with the route of a clinical, COWS score and seeing how she does with time. But I also thought that might be very uncomfortable and, thought it might be kind of protracted. So we did a calculation for an equianalgesic dose of fentanyl and basically stopped the oxycodone and transitioned her to fentanyl about 6 hours later. And we did fentanyl for about 18 hours at what I thought was probably an equianalgesic dose as the oral oxycodone that she was on. And then we did about a 33% dose reduction based on that calculation. And then we stopped the fentanyl knowing that the half-life is much shorter and did our typical kind of induction dose of buprenorphine. Though I'm really attracted by the idea of the micro-dosing. The outcome was basically that, so this is just, at 2 p.m. we tried the 2 milligram sublingual dose, and the patient, this was after 8 hours of washout from fentanyl. So we waited 8 hours from the last dose of fentanyl and gave a 2 milligram sublingual buprenorphine dose. And actually, she didn't like that very much. It made her a little bit agitated, and she had a diarrheal episode. And I thought, well, that's probably an indication that it's too early. So we waited. We gave her a little bit of Ativan and waited another 4 hours, and then we gave her 4 milligrams. And then another 4 hours later, we gave her another 4 milligrams, and she tolerated that quite well. So it was a little bit more protracted than I wanted it to be. But we saw her again in the morning, and her pain was much improved. Normally, after oxycodone, she complains of 8 out of 10 pain, and then after we did the induction, she's down to 5 out of 10, and that's on 4 milligrams 4 times a day. And I'm not 100% sure yet about, my feeling on the alprazolam and the gabapentin is the alprazolam probably needs to be tapered slowly over the course of months, I think. And the gabapentin plus the buprenorphine, I think, is also kind of up for debate. But I'm going to open this up again because Henry has another question. Let me, I think you already are unmuted. Yes, you are. Go ahead.
Oh, yeah, I just wanted to ask, if you're doing the microdosing, do you just keep them on their full dose of oral opiates, or do you titrate that downward as you're titrating the Suboxone off, or as you're titrating the Suboxone on? Like, how would you approach their full agonist as you're titrating up the buprenorphine?
Hi, can you hear me? Okay.
Yep.
So it's variable. Most people, you talk to them about saying, well, decrease your opiate dose gradually so that by the time you're up to 12 milligrams of the buprenorphine, you probably shouldn't be using very much, if at all. Sometimes because of our patients are using street fentanyl and carfentanil, the 12 milligrams won't be enough, and then for their dependents, we will need to move them up sometimes as high as 32. But I think what's attractive to these people is that they know that they don't have to go through this withdrawal, uncomfortable period. They can keep using, but they'll decrease their use, and eventually they won't be using at all. So it's, and we're doing this as an outpatient, so because we don't have an inpatient unit. Does that? I'm not sure if that answers your question.
Yep, thank you.
And actually, Ingrid, timing for bringing that up was perfect. Right before you made your comment, I was pulling up an article I actually had sat down and discussed with Tim, came up a couple months ago when we were talking about a complicated case, and he showed me a paper that was published in 2016 about the Bernese method, which is kind of the trade name for the protocol that you're describing, and they actually kind of go through recommended dosings on it's about a little more than a week schedule for a patient who is actively using heroin, and kind of introducing the doses. Like day one, they have 0.2 milligrams of buprenorphine sublingually, which is a tenth of the smallest strip that we have, while they're using like 2.5 grams of heroin, and very slowly titrating that up as they're decreasing their heroin use. So I think it would be interesting if we start getting more data on kind of equivalent dosings for fentanyl and oxycodone and such, because I can see this being very, very useful in many different settings. I mean, even when we talk about deciding to keep or taper off perioperatively for pain, mostly because we get nervous about sending them home on full agonists and not being able to start their buprenorphine before they leave. And this is if a surgeon was hesitant to keeping buprenorphine on during their perioperative period and they did wean them off and were consulted, this is something we could offer them without having to kind of cut them off cold turkey in a very painful point in their treatment. So thank you for bringing it up. It's actually something I was hoping to talk about in the near future, but I haven't had a chance to do it on any of my patients. So I think it's something to think about.
Dr. Vikas, Dr. Schultz, in true brilliant toxicologist form, just asked, how are you administering these doses? I would imagine it's pretty hard to regulate a microdose like that. You're probably using I would imagine a 1 or 2 milligram strip and then cutting it. Is that?
No, we don't have strips available in Canada because I practice in Canada. So we're using the sublingual tablets, and they come in 2 milligrams. So we can cut them into quarters for the 0.5 milligram and into halves for the 1 milligram. And then after that, it's kind of easy. But just in terms of the last speaker, the other method of doing a microinduction that was published in the literature out of Switzerland was using a transdermal patch with a very small amount, and then slowly increasing the amount of buprenorphine that you give them orally over time while they're continuing to use. So that was an alternative method that was also used in Switzerland.
Thank you.
Any other comments? Particularly, I'm interested about, since I haven't made any, the recommendation I made on the alprazolam was that the primary care physician was going to slowly taper that over time. And I've had a good rapport with the primary care physician, so I think they will. But does anybody else have any thoughts on that? All right, I'm getting crickets, and here we go. Henry,
typically,
go ahead.
Typically, we'll try and switch them over to something longer acting because we hate alprazolam so much, and just that it's rapid onset and off and stuff, that it kind of just perpetuates the further desire and use of it. So we would prefer to switch them to an equipotent dose of clonazepam before doing a taper. It would be our typical approach to it. But again, I think if you're not going to be the one doing it, then talking with the doc who is going to be the one doing it is probably good, because these things do take forever. And so making sure your approaches are in line makes sense.
Great point. All right, I'm going to turn it over to Jade.
Before I get started, is
Tim on? No.
Tim on?
No, in fact, there's a text that he's.
All right.
Yeah.
Just us, Jade.
Fantastic. All right. So this next case I'm going to talk about is a 21-year-old female who presented to the ED self-reporting a seizure episode. It's kind of unclear based on the history if this was she had a witnessed event or if this was a self-report, but she described running out of her Xanax. She didn't refill it. Her exam was pretty benign when she presented, just minimal tachycardia, normotensive, appears anxious with a slight tremor, but not confused and is talking to us.
Did I hit that button there? See that down? Nope, the down one. Yeah.
Kind of even before seeing the patient, looking at the prescription monitoring program, looked like she should have had plenty of her Xanax, and she's also prescribed Suboxone, as well as 2 different amphetamines. So she, looking at our electronic medical record, we were also able to review a recent ED visit where she required Narcan for an overdose and reported a history of also using cocaine. In addition to that, it appeared she had also been started on baclofen, QID, for the indications of cocaine craving as well. So as a consult, she was kind of verbalizing to her provider she was really concerned she was going to have a seizure if someone didn't give her her Xanax. So when thinking about a patient like this with many different potential substance use disorders and coming in with not quite a normal exam, but definitely a history that's quite concerning, what are the first things you might want to do seeing this patient in the ED, given the information that you have in the medical record and your exam?
You can unmute him there. Although I don't know if you forgot to take
No, I don't know.
Yep, right here. You gotta unmute him. There. Because he's hand up. Henry, did you have your hand up from before, or? No.
Oops, yeah, I left it up again. Sorry.
Would anybody be willing to start her on benzos, admit this patient, discharge her home, call her providers, lots of different options.
All right, I'm going to help out Jade by singling some folks out again. How about Dr. Murphy? Oh, I don't think that I have an audio listed for her. She might be one of these call-ins. I'm not sure. What else do we got? Oh. Let's see. Heather Borick?
Yeah, I hate Xanax for this reason. We don't quite have a setup for buprenorphine prescribing here, although we're looking to move to that. But whenever someone comes in with, Xanax and symptoms of withdrawal, I do worry about their seizure risk, and we'll substitute another benzo for that, like an Ativan 1 milligram dose, but keeping in mind that Xanax does seem to be its own beast with withdrawal, and sometimes substituting other benzos doesn't fully treat the withdrawal phenomenon.
Okay. And I think definitely considering does this patient, especially if she has a high level of dependence and monitoring her over a period in the ED if she develops any symptoms of withdrawal, and if you're not willing to send her out with more benzos, certainly bringing her in the hospital and either coming up with a taper plan or at least monitoring for clinical signs of worsening withdrawal is definitely important. I think if we decide to send her home, there's a high chance she'll be back probably with a seizure if this is if she's been taking it as much as she's been prescribed. The other question is has she been taking it as she's been prescribed? Is she truly dependent, or is there some secondary gain in play as well? And then as well as kind of discussing about her buprenorphine, she obviously has a provider who is very aware of her multiple other controlled prescriptions because of the prescription monitoring, as well as her stimulant use. So people that are here and those that do prescribe buprenorphine, what's your typical practice with your policies for co-prescribing with both benzodiazepines and stimulants?
I'm actually interested to hear what you have to say, Dr. Bishevitz.
So prescribing, so as far as prescribing benzos with stimulants, I'm always suspicious of that because I'm not sure why you would need a benzo and a stimulant unless you have, for sure, important diagnoses of panic disorder plus attention deficit disorder that is verified by many people. So that's always sort of a concern because you worry that people are taking the stimulant in the morning to be stimulated and get energy, and then taking the benzo later on to calm down. That's always a thought. So I know people make different decisions when they're working in a private practice. For example, I work in a facility that is part of alcohol and drug treatment. So what we normally say is we don't even accept new people for buprenorphine who are on benzos. We ask them to come to us without benzos in their urine and start the buprenorphine then because it's just been such a very difficult problem. It's just something that's bought and sold outside the clinic doors all the time. It's just a very concerning thing. Now, as far as stimulants go, that's a whole different case because there are plenty of people who have both attention deficit disorder and various drug use disorders. So we try to be judicious with that, and when people are in good recovery from other substances, and we verify, especially using third-party verification of the symptoms of attention deficit disorder, there are some carefully selected people who are on stimulant meds for that reason.
Can I ask you, you mentioned that in patients who have benzodiazepines in their urine, you don't accept them into treatment for buprenorphine. So in your mind then, what is the best way to get somebody who has both, like a codependence of, or a habit of both opioid and benzodiazepine into a stable situation? Is it to first address the benzodiazepines and then address the opioids, or?
So we have changed recently in that because of the opioid crisis, there's been some advice from various places, including New York State OASIS, that we should be a little more kinder and gentler towards people who are using benzos. And we will take people and have them on lower doses of buprenorphine while they're using their benzos, and we're talking to them about getting off of the benzos. So there's no definite sequence of events, but we will try and engage them in treatment in that way.
I just wonder if it would make sense to put them in a detox setting and either do a phenobarb taper over a course of days to get them off the benzos and onto a maintenance drug for their opioid dependence disorder, if that's maybe the answer to what to do in those situations.
Well, I think that would make a lot of sense if it worked. I think there are plenty of people who are detoxed off of benzos with using phenobarb, and it does work in that the patient is safe, but the relapse rate is just tremendous because the patient has a benzo use disorder. So I think you need to work more long term with people with benzo use.
Suzanne?
Hi, can you hear me?
Yep.
Okay, great. I'm in an airport, so if you hear airport sounds, that's what that is. I just wanted to say two things. I believe the FDA changed the labeling on buprenorphine to say it's now okay to prescribe buprenorphine to people that are on benzodiazepines, because for a long time, one scared off the other. But more importantly, there was an article written, I want to say in the last couple of weeks, I think it's the Annals of Internal Medicine, and it's buprenorphine 2.0, and it has in there a couple of recommendations, but one of which is if your buprenorphine patient is also positive for benzos or also uses benzos, this is not a reason to kick them off treatment or deny them treatment. It's a reason to engage them into more treatment to deal with the benzodiazepine issues. So I just wanted to point that out. There are a lot of movement towards giving access to care, increasing their care, engaging them on these issues. And I want to say that, I think this patient is either 21 or 24. She's on the Suboxone, she's on benzo, she's on baclofen, so, and then on the a stimulant or the presumably the amphetamine. There are a lot of issues here, but a lot of CNS depressants. She's probably really sleepy during the day, so she needs the amphetamines to keep her awake. I think all those issues need to be addressed. And she might be having seizures because she's overusing her baclofen, or she's in baclofen withdrawal. She could be seizing because she doesn't have access to her benzos. She could be seizing because she's taking too much of her ADHD meds. There are a lot of potential issues here. That's all I have to say.
So really, in a case like this, one of the ideal things would be inpatient rehab, because you could observe some of these things over a few weeks and see what happens.
Okay. All really good points, and I think we'll kind of talk about her ultimate disposition, but I think you bring up a really good point that the fact that she's here at all gives us a chance to intervene on a particularly high-risk patient. And I think we as providers that are interested in this topic, we're here learning every month about patients like this. This is an obvious red flag, but I think you would be surprised when patients present how often these things get overlooked. So I think it's just a really good conversation. So for her, labs were sent off. Nothing too remarkable there. CK's within normal limits. Sometimes that's used to kind of get a sense if a patient actually had a clinically significant seizure, although the data on that is not supported in the literature, and it's something that sometimes we see. Her UDS doesn't show anything surprising except for additional THC. I'm actually not sure with her opiate screening positive if that was confirmed to be which one, but that's definitely something to talk with the patient about because she's supposed to be on buprenorphine, and it doesn't appear that any buprenorphine metabolites were either sent. So she was given Valium by the ED provider. So we had talked about kind of using a longer-acting benzodiazepine, and she was admitted to the med psych unit. So there was a description of this possible the way that it's described may be a pseudo-seizure event where she was shaking, but as soon as someone kind of told her what she wanted to hear, she kind of stopped. Is there anything anyone else might do differently for her disposition? So she's, our medical psychiatry unit can be a telemetry floor, but it's floor status, and they will provide medical care. They'll treat seizures. They can handle anything a regular floor could do, but in addition, they have a psychiatrist that can assist with both any underlying psychiatric disorders and can kind of help with the addiction component as well. And I guess I kind of talked you through it a little bit, but then what would you do about her buprenorphine right now? Still getting to know everybody on this chat, so I don't want to blindly pick out a poor soul, but...
Oh, no, blindly pick. Brian Murray.
I also like the name Brent, so we'll start with Brian, and Brent, be ready.
Unmute. Yep, hit that unmute button. Yeah. All right.
Brian Murray.
Brent Morgan.
Yeah, I'm sorry. What's the question?
So what would your approach, so she's admitted to the medical psychiatry unit. Is that an appropriate place for her to be? What are your other options for disposition for this patient? Would you consider sending her home? And kind of what are our first steps for what meds are we going to continue for her while she's here to try to keep her kind of engaged, but also addressing the things that she's at risk for? You can answer any of those if you'd like.
So I haven't been able to really pay attention, been distracted by another case we have going on. What are her vital signs?
Oh. So her vitals, she has a mild sinus tachycardia, heart rate of 100, a mild tremor. She appeared to have maybe a pseudo-seizure in the department where she kind of aroused after some reassurance that we would be giving her a benzo while she was here. Her urine drug screen, so we know that she's on, or she's prescribed buprenorphine, Xanax. She has been using cocaine, but is also prescribed baclofen, and she's screening positive also for opiates and THC.
And she's requesting assistance
she's
to try to...
She's requesting a refill of her Xanax.
Refill of her Xanax.
Because she had a seizure at home. And
is she willing to go into inpatient for therapy? It sounds like you guys did admit her there. So I think that sounds reasonable. I wouldn't feel comfortable, prescribing her a benzo from the emergency department with no follow-up or, anything like that. Not really be able to implement a tapering plan. So I think that seems like a reasonable, trying to get her some inpatient observation and care. So I would probably be most worried initially about the benzodiazepines and want to monitor her for going into withdrawal from that, and whether she is going to have a true seizure or just anxiety and pseudo seizures.
Sure. And then as far as continuing or not continuing the buprenorphine that she's prescribed, what are your thoughts on that?
I'm a little concerned that her UBS is showing opiates. I might try to send out a more comprehensive screen on that in the meantime to see if she is taking any of her buprenorphine. So I might hold it for a while and see what kind of symptoms develop from that standpoint.
Perfect. I agree. All right. So patients, the prescriber of her stimulant and her benzo was contacted, and that there was concern that while there are things that are positive on the UDS that are there, she also doesn't have any positive amphetamine. And we kind of got her primary care doctor on board while she was here, that this provider would not continue the benzo and stimulant prescriptions given the concern for diversion and misuse and things of that nature, if we could take care of the detoxification acutely as an inpatient. She got very frustrated, but at least was amenable to considering a barbital protocol for detox, which is something that I'm interested to see if any of you guys use at all. Additionally, she really didn't want us to reach out to her Suboxone doctor, her prescriber, and just got very hostile about that. And then she did admit to using heroin, and kind of gave a mixed picture about going back on her Suboxone. So I guess, and we can kind of continue through the case, but what are people's thoughts about protocols for benzo tapers, and has anyone ever used the phenobarbital protocols?
All right, Elizabeth Bilden. Elizabeth, you're unmuted if you got your hand up.
Thank you. Just jumping back to the previous part for just a minute, what do you mean that she was giving sort of a mixed picture in terms of wanting or not wanting to be on buprenorphine? She does or she doesn't want to? I understand she doesn't want her doc to know, but was she finding that, does she want to be on buprenorphine?
It's not clear to me, and actually I did not see this patient during this phase, but she had been struggling with staying on Suboxone because she had been using, and it was kind of described, she had gone back on it, but she was ambivalent about continuing.
Okay, so that makes sense to me in terms of if she's okay with holding it, on holding it right now. I guess I was wondering what other folks thought in terms of, if this is a voluntary admission and she has opioid withdrawal and chooses to leave because we don't treat the opioid withdrawal adequately, and if there's a question if she wants to be on buprenorphine, I guess I would have thought to continue that part, even if she's got opiates in her urine.
I think
different if she doesn't want to continue. I understand that.
Absolutely, and I think the main point that was made was at least having a suspicion that she had used at least recently something like a full agonist, and that not blind, because her UDS was positive for opiates, there was not a buprenorphine screen, but at least we knew that she had at some point taken something full agonist and not just not plugging her home meds in and precipitating withdrawal. So for a patient that originally wasn't super forthcoming, being able to take the hard information that we did have and at least ask her the question and frame it in a way of, it looks like maybe you had a relapse with opiates, and we want to be able to treat withdrawal when it eventually does come. So we just want to make sure we do that at the right time and working with the patient and finding the right time to restart Suboxone if that's something that she needs.
Okay, thank you. And somebody else also used the word, I think, beast in terms of the alprazolam withdrawal. Incredibly concerning, I think, and at times very difficult to manage because of how quickly and what is such a severe withdrawal compared to other benzodiazepines, so the inpatient setting. And I have not, with the kind of moving forward, I have personally not used phenobarbital, but would on a rare occasion just to say, let's try a dose of this. But in terms of a protocol, or I would be eager to hear others because that seems like a really good way to go.
We can talk about our dosing in just a minute too, but if anyone else has any comments about their programs, it looks like a couple of people have their hands up. I think Henry, you were up.
Yeah.
Henry, you're muted.
Yes, we don't exactly have a protocol for detoxing off of benzos with the phenobarbital. We do use it from time to time. We'll kind of basically write them out a taper where we'll get them try and get them somewhere in the range of 10 milligrams per kilogram PO in the first day, and then kind of taper them down off of it over the next 2 days. But the one question or the thing that's always been troubling me is, do you do those protocols on patients who are on Suboxone? So, I guess if they're in an inpatient setting where they're monitored, I feel more comfortable with it. But there's all this concern about benzodiazepines and Suboxone, and now you're adding partial agonist opioid on top of barbiturate, and I'm certainly worried about respiratory depression in those patients. Even after they were to leave the hospital.
Yeah, so let me see if I can skip forward to our protocol a bit. It might help answer your question. So similar to kind of the test dose concept that we use for buprenorphine to make sure we don't precipitate withdrawal, kind of is twofold. We also don't want to precipitate overdose in someone that's not dependent. So in this case, we often will do oral 130 milligrams of phenobarb and kind of wait for a few hours and see what happens. And if we don't see any increased somnolence, we usually do move forward with the protocol, which day one is 130 milligrams every 4 hours for 24 hours dosing. And if there's any sedation with any dose, we'll hold a dose and reassess. And keeping in mind, if we're concerned about the interactions at all, they can remain on pulse ox. They are in a monitored setting, and escalation of care if needed. There's always a risk, but I think the bigger concern would be, this patient is using high doses of medications in an unmonitored setting, so if we're going to do this, this is the best place to do it. And then the protocol continues, just decreasing in frequency of the dosing, spreading out from Q4 to Q6 to Q8 hours over 3 days. And then like this kind of case illustrates, we had continued her buprenorphine while she was in the hospital, and we kept her on a BID dosing rather than her typical TID. Does anyone have questions about this kind of, or Henry, you still have your hand up, but this kind of approach to using the phenobarb, besides the excessive sedation, which
I think it's a valid point that you bring up. I think, particularly in the post-hospitalization part of the patient's care, because phenobarb has such a long duration of effect. I will say that when we use this, and we do it quite frequently, we actually examine the patient after that test dose, and if they're showing any signs of sedation, I think that tells you right away that this is not the way to go. Dr. Vikas?
I don't have a comment about the protocol per se, but I am wondering about the comment that was made about that her UDS was negative for buprenorphine or its metabolite. And so what was she doing with her buprenorphine? Was she diverting it? And were there any issues or risks with restarting her on her buprenorphine with clear objective proof that she wasn't probably taking it.
Right. And actually, in this patient, so our standard urine drug screen does not typically screen for buprenorphine and metabolites. Based on the medical record, I have not been able to find a negative buprenorphine screen. So I can't definitively say she wasn't taking it at all. I think there is a concern that she was taking it irregularly at best, and certainly addressing that in a close outpatient follow-up is really important because she's definitely been misusing her medication.
Thank you.
All right. The one other thing I wanted to bring up before is kind of how people treat cocaine dependence and craving in their patients. This patient had been prescribed baclofen 3 times a day with the sole indication of cocaine cravings. Does anyone use that, and what are other options for cocaine? We do see cocaine quite.
Nothing works.
Yeah. You said nothing works. What do you think, Jay?
Yeah.
Yeah. So, go ahead. So one of the other, I mean, nothing works well, I think, is a good summary of that. A couple of things that have kind of come up some is the use of topiramate, as well as disulfiram. I would say the one thing I've seen anecdotally work in some of our patients is the lower doses of topiramate, but that is hit or miss at best. But I like it better than the idea of adding baclofen, just especially in this particular patient. Has anyone had any success with any of these medications for cocaine cravings?
I just want to say that I've offered people disulfiram for cocaine craving, and we've talked about it, but just cognitively, people just don't like the idea of it. They don't quite understand why they should be taking this, and I haven't sold very many people on it at all.
Ingrid, you have your hand up?
I inherited a patient who had been started on topiramate for her cocaine cravings. She also had an opiate use disorder, so we were seeing her primarily for that. And just in my N of 1, she had described that her cravings for cocaine had decreased by about 50% or so, but they weren't gone completely. And while she continued using cocaine, it was certainly at a much lesser level than previously and was more manageable. But that's my experience with an N of 1.
Okay, thank you. All right, so unless anyone else has any comments or questions at this point, I'm going to try and move through one more case quickly in the 10 minutes we have. All right, so we kind of touched on all of that. All right, so we have a 32-year-old male who came to kind of a detox facility, so not facilitated with the not with the hospital. He uses a bundle of heroin a day, as well as 8 mg per day of clonazepam, total daily dose of nearly 3.5 grams of gabapentin, and has an interesting UDS, including buprenorphine. And so as he presents, and I can kind of go back to his initial UDS as well, but what type of regimens for detox, and whether that's buprenorphine or otherwise, could we offer this patient? And given his multiple substance uses, does that change kind of how you approach him?
Does anyone on the line staff detox clinic? Or detox center, I should say. It's interesting that nobody.
Yeah. So, I mean, we've touched on a lot of these things periodically throughout this conference, but kind of from the outpatient detoxes protocols, certainly making sure, and this is kind of instead of starting them on buprenorphine with the plans for maintaining, but how are we going to, how could we wean them off of opiates without the plan to continue? And this is kind of outlining a way that we could do that over the course of a week, and then you'd have the option to continue maintenance if you were able to establish follow-up. And this kind of follows a similar induction dose of 2 milligrams that we do to make sure we're not precipitating withdrawal, and then kind of giving an 8 milligram total daily on day 1, and then while they're there, instead of continuing on the higher doses over the course of the week, kind of on day 2 and 3, doing 8 split BID, 4 daily on day 4 and 5, and then just 2 on day 6 and 7. And then that kind of helps decrease the severe symptoms of withdrawal using clonidine and hydroxyzine as needed.
Yeah, Jade, you know, it's interesting because I get a lot of these cases. I look at so many eye stops that I can tell when somebody's been to one of our local detox programs, because it's usually a prescription for 16 strips of buprenorphine naloxone and a couple of tablets of diazepam, and they get it filled, and then they take it back to the detox clinic. It's interesting because I'm interested to hear what other people think. It seems like from my subjective single provider view, half the people say that doing this kind of detox is just as painful as detoxing from street full agonists. And then the other half of people say, no, wait, this is way better. I wonder what other people have observed.
Or has anyone inherited a patient that's gone through this as well and heard their experiences if you're not doing it? That is kind of a different way to approach the use of buprenorphine. Deanna Dean. Richard Tovar.
All right, so what do you think, Dr. Mashevitz?
Well, I just want to say that I really like the New York State definition of detox program because we have something now called ancillary withdrawal program, and it addresses sort of any possible scenario. So with this ancillary withdrawal program, which is a outpatient program, we can either detox people off of opiates using buprenorphine, or we can get them on the buprenorphine and keep them on it, keep them in our program, which is a great thing. That's what I'd say over 50% of them want. Or if they don't like the buprenorphine, we can get them onto methadone. So it really addresses every possible thing. We could also get them onto Vivitrol if we really want, if they really wanted to. We haven't had much call for that.
I think the other thing that this touches on as well is the use of Valium as opposed to our last case where we used phenobar, but it's a similar concept. And then another thing to consider for this patient, he was on a pretty large dose of gabapentin as well, and I find that gabapentin and Lyrica and kind of the reasons why they're started on them are important, but are almost just as tricky to get a patient on board with discontinuing. And we only have a few minutes left, but as far as what would you do regarding this large dose of gabapentin in this patient as well?
I just want to say that whatever you're doing with any of these things, you can't do it in the 5 days or whatever it is that you have for the detox.
Yeah, sometimes it's just addressing these things, kind of peeling them off one layer at a time, and I think the key is really understanding why the patient's on it. Sometimes I find, there's a good chance the patient has true neuropathic diabetic pain or had a severe injury, and it's kind of in a similar way we handle stimulants, trying to really work with the primary care physician and addressing if this is a true pain issue, is this really indicated for neuropathic pain, or is this something that we should work with the patient to slowly taper off safely? And if not completely taper, at least bring them down to a lower dose. All right. So I think we're going to stop here today. Thank you for kind of exploring different options with us and for bringing up some ideas for us to try with our patients as well.
Thanks, everyone.
Thank you. Bye.
Bye.
Have a great Thanksgiving.
Happy Thanksgiving.